Good morning. My name's Dr. Mark Livingstone. I'm the Deputy Medical Director at Genea. Welcome to our first webinar, which this talk is normally given by me face-to-face down at Genea, but of course in current times that's not possible. We have just reopened for IVF procedures. The government gave the go-ahead from yesterday. So I'm going to take you through a whole load of fertility information, and then there will be time at the end for you to ask any questions. So let's just get started.
Today we're going to talk about infertility, the causes of infertility, some treatment options. It's not all about IVF. A large number of patients that I see will not proceed on to IVF because other things are more appropriate. I will take you through IVF, which will be the bulk of the talk, take you through the laboratory, what happens with eggs and embryos in the laboratory, and then talk about your options if you decide to move forwards with any investigations. So first of all, I'm going to talk about infertility, age, and sort of other factors. So age of a woman is important because as a woman becomes older, the chance of pregnancy reduces, the chance of miscarriage increases, and the chance of a chromosomally abnormal pregnancy also increases. So usually GPs and doctors will always talk about the age of 35. And if a woman's been trying for under 12 months, we usually say that's infertility. And women over the age of 35, we can say that around about 6 months. These are sort of arbitrary cut-offs. And if you wish to be tested far sooner than 12 months if you're under 35, I don't think that's an unreasonable thing. You want to know you've got your best chance of pregnancy over the next few months if you've been trying for 6 months. As I said, age does have an effect. So the chance of pregnancy around about the age of 35 each month, if everything's normal with you and your partner, is around about 16 or 17% per month. That chance drops. And at the age of 40, you're going down to about 7% chance. At the age of 45, it will be about 2%. But added to that, that's just the chance of getting pregnant. The chance of miscarriage increases, as I said, and the chance of a chromosomally abnormal pregnancy increases with age. So therefore, as you become older, it's not just getting pregnant, it's holding on to the pregnancy and obviously having a chromosomally normal pregnancy. So I usually explain fertility as 4 basic things. Number 1 is a woman releasing an egg, ovulation. Number 2, does a man have sperm? And we look at the sperm numbers, movement, and shape. Number 3, can they get together? Are the fallopian tubes open? And number 4, is there a normal lining of the womb for the embryo to implant in? They're the basic tests I would recommend. But of course, there can be other causes for infertility, such as endometriosis or difficulties with intercourse and unexplained infertility, which 1 in 6 couples do IVF for unexplained infertility. And that's when we've done all the tests and we can't find anything wrong. And those people will go on to do IVF, not because they can't get pregnant, but because it's not happened by that point in time. And they could still conceive naturally at any point. Multiple factors can have a major effect on your chance of pregnancy. If a man has a slightly lower sperm count and the woman has mild endometriosis, those 2 factors add to each other to really delay the chance of pregnancy occurring. In that scenario, if you fix endometriosis, or remove endometriosis rather, then you will improve the chance of pregnancy because you've now only got 1 factor that is holding you back. Lifestyle is one of the commonest questions I get asked, and the main things that we as doctors pick on: smoking, definitely, especially cannabis. Caffeine is a controversial one, but usually we say 1 cup of coffee a day. I don't drink coffee, so I don't understand the addiction. Alcohol in moderation. Now, if you want to stop alcohol completely, that's totally fine, but we don't say to absolutely stop it. Weight is really important. Being underweight can stop ovulation, and being overweight can also stop ovulation from occurring, plus also increased risks of diabetes during pregnancy, high blood pressure, etc. One of the commonest questions I get asked is, does stress affect my chance of pregnancy? It's a difficult one because no one's been able to measure it accurately. But we say to try and reduce stress as much as you can, but we can't say whether it does or doesn't. And unless a woman is so stressed that she stops ovulating. That would be the main sort of physiological effect of stress. Now I'm going to take you through a few treatment options. And option one would be to go on and do some ovulation tracking, especially if your menstrual cycles are a little bit irregular. So one's 35 days, one's 42 days. And we count the menstrual cycle from day one of the period to day one of the next period. So day one of bleeding to day one of bleeding. And one of the options we have at Genea is ovulation tracking for 3 cycles, which is at no cost. This involves blood tests around the middle of the cycle. So day 10, 12, 14, 16 for a 28-day cycle, because ovulation should happen about 14 days before the next period comes. And of course, if you've got a 35-day cycle, the blood test would be around about day 21. So it can help you pinpoint when to have intercourse and also reassure you that you've got a good progesterone level 7 days after you've ovulated, to reassure you that that level's good. Second option are ladies who do not ovulate, and we can use tablets such as letrozole or clomiphene, or injections of FSH, follicle stimulating hormone, to make ovulation occur. More commonly, it's letrozole to start with. It's quite a simple process. It's a tablet from day 2 to 6 of the cycle, again with the tracking just the same as the ovulation tracking. But we also add in an ultrasound to check and see that there's only one little follicle developing. Because if there are multiple follicles, if the tablets work too well, then there's a high risk of a multiple pregnancy. And a lot of people want to have twins, but there are more risks for mums, more risks for babies, and the divorce rate's higher. So we try and have one follicle if we possibly can. So intrauterine insemination is another option. And that is when we get your partner's sperm or use donor sperm and pop it inside the uterus on the day of ovulation. So it tends to be for when you can't have sex, there's a physical issue, or your partner might be overseas, or again for donor sperm. Don't tend to do it for people who are having intercourse, because it doesn't really change your chance of success unless you use some medication to try and help you to produce more than one egg. And it's the extra eggs that give you more chance of pregnancy rather than the physical putting the sperm inside the uterus. Next option would be IVF and ICSI, which I'm going to take you through. There are options for egg donor and sperm donor at Genea, although there are limited numbers of people who've frozen gametes for us to use, because in New South Wales there are quite strict regulations on who can donate sperm and eggs, and they can only donate to 5 families, including their own. And the last option would be egg freezing, to try and preserve fertility at the age that you are. So it's preserving, if you're age 35, your chance of pregnancy of 35, miscarriage of 35, and Down syndrome, for example, chromosome issues at 35, even if you're 40 when you go ahead and use those eggs. Fertility assessment, the test that we would quite commonly do, and often you could do this with the GP at Genea, is just to determine whether simple things are happening, such as an egg counting test, an AMH, a sperm test, an ultrasound to check the uterus is normal, and sometimes also checking the fallopian tubes. And that's a free assessment with our Genea GP. The next would be ovulation tracking, with blood tests around the middle of the cycle when ovulation is expected. And again, that is a free service for 3 cycles. Ovulation induction is using tablets such as letrozole or clomiphene to induce a follicle to produce an egg, with tracking with blood tests and ultrasound done around about the middle of the cycle. That costs about $550 per month. The fourth option is intrauterine insemination, where sperm is injected directly into the uterus, and usually this is performed when donor sperm is used, when partners overseas, or there are physical issues resulting in an inability to have intercourse. The physical squirting of the sperm into the uterus doesn't usually change your chance of pregnancy significantly if you are actually having intercourse on your own. The only way that it does increase the chances is if you use some tablets or injections to try and boost the number of eggs, and it's the eggs increasing your chance of pregnancy rather than the insemination. Next, is egg freezing. Now, egg freezing, it unfortunately doesn't attract any Medicare rebates. Genea has had the first dedicated clinic for egg freezing, and it's a separate part of the clinic. Egg freezing involves taking some medications, the same as the IVF process, which I'm just about to explain, to make more than one follicle grow and to collect eggs. It's not a guarantee of success, but it does help to improve your chance of pregnancy if you collect your eggs at the age of 35 and then use those eggs when you're 40. Much lower chance of miscarriage, much lower chance of Down syndrome. The next thing I'm going to take you through is IVF, and I'll explain the process from start to finish. Assisted conception is often labelled IVF, but that's a way of actually fertilising eggs. So in vitro fertilisation is getting eggs and mixing sperm with them and letting the sperm penetrate the egg on their own. ICSI is a second way of doing assisted conception where we get the eggs and strip all the cells from around the outside, immobilise the sperm and inject the sperm directly into the egg. Now, a lot of patients want to have ICSI because it sounds like you would get better fertilisation with it. But actually, if you've got normal sperm, IVF and ICSI result in very similar pregnancy rates. ICSI is really for people with abnormal sperm tests to try and give them the same fertilisation rate as people with IVF. So the IVF process, what does it involve? Well, first of all, it involves some injections to make more than one egg develop. And we want to know how many eggs someone might produce before embarking on a cycle of IVF. The tests that we do are, number one, an ultrasound to look at the size of the ovaries. Number two, on the ultrasound, also look at the number of follicles, the number of little cystic structures that you can see on the right-hand side, to see how many follicles there are there starting. And number three is an AMH, an egg counting blood test. So before starting any treatment or just for investigations, I'll often do these three tests to check ovarian reserve. All of this is irrelevant for trying naturally, because naturally there's only one follicle that releases one egg usually into the fallopian tube. And it doesn't matter whether you've got 20 follicles starting there on day one of the period or whether you've got 2 follicles starting there on day one of the period. As long as one gets released, then you have a chance of pregnancy. In the process of assisted conception, we give a drug, or you give yourself, sorry, a drug called follicle stimulating hormone, which makes all the follicles that are starting to grow on day one keep growing. So we're not using up eggs, we're not putting people into menopause, we're just making what's starting to grow keep growing. And so people with big ovaries, with lots of follicles and a good high AMH will produce the most eggs, and the reverse, of course, is true as well. This doesn't tell us about quality of eggs, doesn't tell us how quickly someone will get pregnant, doesn't tell us who will have miscarriages. It purely tells us how many eggs we will actually, it gives us an idea of how many eggs we will actually produce from the cycle. The process of getting the eggs to stimulate is usually 5 days of one injection, which you give yourself into your tummy, follicle stimulating hormone, followed by 4 days, roughly, of a second injection to stop ovulation and prevent the eggs from being released early. In that time, there'll be a blood test day 1, blood test day 4, and blood and ultrasound about day 8, day 9, to watch these little follicles get bigger. And when they're around about 14 to 19 millimetres, these little cysts, that's when we think they'll have an egg inside them. But the egg's very small, it's 1/10 of a millimetre. So we can't see the egg, we have to just go on the sizes of the follicles. Bloods and scans are usually done between 7 and 9 in the morning to enable you to go to work afterwards, and we'll phone with results of what your tests mean around about 11 or 12 that day. When the follicles are the right size, if they're all around about 14 to 19 millimetres, we'll say we're ready to collect the eggs. Now, you don't have to drop everything. What we actually do is tell you to give yourself an injection of HCG, most commonly, into your tummy that night, and 36 hours later, we will collect the eggs. You would actually ovulate and release the eggs about 39 hours after that injection. So we're getting the eggs when they're nice and ripe and mature, but just before you would actually ovulate. So we time it all perfectly. You know roughly when you start the cycle when your egg collection will be, but not exactly. When it comes to the day of egg collection, I usually do my egg collections with people with some painkiller through a drip and local anaesthetic inside the vagina. And that way both of you can come in and can actually watch the procedure as I drain the fluid from the follicles. And you can see the fluid going into the test tube and see the scientist look through the fluid and pick out the eggs. It takes about 15 minutes. Now, some people may choose to have a general anaesthetic, and some doctors do actually choose that you have a general anaesthetic or heavier sedation. But most people are actually surprised how little they feel with it. You do tend to feel a bit more uncomfortable afterwards rather than during the procedure. Now, once the eggs have been collected, we send the male off for a sperm collection or frozen sperm if we're using donor sperm or in certain circumstances. So we try to use fresh sperm on the day. In the case of a vasectomy, there'll be no fresh sperm to collect from an ejaculate, so we might do a testicular biopsy to try and retrieve the sperm directly from the testicle and inject it into the eggs by the ICSI process. So next I was going to take you through the laboratory. And this is where we, as it says, fertilise and nurture the embryo. The insemination process, as I explained, will either be IVF mixing the sperm and the eggs together or going on to do ICSI and injecting a single sperm directly into the egg. We're now going to show you a video of IVF and the ICSI process. In ICSI, the sperm is immobilised and then injected directly into the egg. The embryos are grown to the day 5 stage. So that means if you had an egg collection today, 5 days later, you would be looking at the embryos to try and put one embryo back into the uterus. As I've said before, we put one embryo back to try and avoid the risk of multiple pregnancy, but there is a 1% chance of identical twins from IVF. Most twins naturally are actually 2 eggs and not one that has split into 2. It's about 1 in 300 naturally, and we don't know why it's an increased number of identical twins from the IVF process. A few hypotheses, but no definites. So if you had 20 follicles on the ultrasound, you might collect 10 eggs because they're not all going to be big enough. From the 10 eggs, when you put the sperm with them, maybe 6 or 7 might fertilise and join together, and we'd know that on day 1, when you can see the 2 little discs, as you can see on the left-hand picture, showing the sperm and the egg's genetic material ready to join together. On day 3, the embryo becomes an 8-cell embryo and then goes on to compact. And day 5, the third picture, is the blastocyst, and that's what you want to see on day 5. You can see a nice inner cell mass in the middle, clump of cells, that's the part that will form the baby. And you can see the cells around the outside, the trophectoderm cells that will form the placenta and membranes. We do also sometimes hatch embryos to try and get some of the cells from the embryo to hatch out of the little shell. They do that naturally, but sometimes we might do that a little bit earlier if we want to do testing on the embryos for chromosomes and to check their genetic material. So we have special Geri incubators, and we develop these and we do sell them around the world. And they're special little incubators just for your embryos. They're in their own containers, so as we don't have to take them out, we don't disturb them. Embryos are very sensitive to temperature change or changes in oxygen or carbon dioxide. So they're all temperature controlled. And the beauty of these machines are we actually have time-lapse photography on there. So we can actually watch the embryos as they divide to check how well they divide, are they uniform, what the quality is like. And it gives us a lot more information than we had before when we were checking embryos, say, on day 1, day 3, and day 5. So it's really helped us improve pregnancy rates. And I've got to say, I like going into the lab and seeing how the embryos look, because you get a really clear picture before performing an embryo transfer. GEMS is our special culture, which we use with the machines, which has been developed over many, many years to choose the optimal conditions for the embryos to grow. Grow is actually a way for you to look at the embryos as they develop in the laboratory. And we will actually send you a snapshot of the embryos so as you can actually track them on your phone or iPad or laptop. And you can keep those pictures for posterity as well. Just going to show you a video of an embryo developing inside one of the Geri incubators at Genea. Gavi is also a Genea invention, and it's a semi-automated way of freezing embryos and eggs. We put embryos in at the beginning, and they come out frozen in pods. So it takes a lot of the manual handling away from the embryologists. GeneSure, all these things start with G because we are Genea, is a way of testing the embryos to look for their chromosomes. Now, before starting a cycle of assisted conception, we will check the chromosomes from both the male and female to check that there are 46. When we put back embryos, we're just looking at the outside of the embryo. We're not looking at the inside. And GeneSure is testing the inside to look and see if the embryo also has 46 chromosomes. Because a number can look good on the outside, but have an extra chromosome or a chromosome missing. In order to do this, we have to hatch the embryo, as I showed you in the previous slide. The embryo's got to push out some cells. We've got to chop off those cells and freeze the embryo to wait for about 2 weeks for the results to come back. And that lets us look at the outside of the embryo. So that looks, pause. That lets us look at the inside of the embryo as well as the outside to try and reduce the risk of miscarriage and reduce the risk of a chromosomally abnormal pregnancy. It does have benefits, especially for people who've had multiple miscarriages or for older women. It does also have some drawbacks as well, and that's something to discuss with your specialist. I don't recommend it, for example, for every younger woman because they will have a lot of chromosomally normal embryos, and there can be some issues incurred from testing the embryos that we might get no result from the embryo, or the embryo might not survive defrosting. Well, it's only about 1%, but if you've got one embryo, you're able to test it, and then it doesn't survive, you'll wish that you'd not done the testing if the embryo was chromosomally normal. Now, just going to show you a biopsy taking place on a video. The reasons that you might embark on genetic testing are if you've got a genetic condition in the family, history of miscarriage, number of embryo transfers without implantation occurring, or for advanced maternal age. But as I said, it's not for everybody. Next, we have the embryo transfer, which is day 5, usually. We stopped doing day 3 transfers around about 2002 because growing to day 5 helped us choose the best quality embryos and gives us the highest chance of success. Usually a nice, simple procedure, much like a pap smear. Pop the catheter inside the uterus, and at the same time, the nurse is usually holding an ultrasound probe on the tummy so that we can actually watch the little catheter go into the uterus and release a little air bubble inside the lining of the womb. So we can see the catheter coming in, we can see the little air bubble release to reassure us that we are in the right place. The worst part of this procedure is usually having a full bladder to try and time how full your bladder is going to be and not be absolutely bursting before the time of the transfer. But it's a nice, simple procedure. And then it's an 11-day wait for a pregnancy test. And that's often the worst part. I know there are a lot of physical parts to the stimulation and the egg collection and the embryo transfer, but many patients will say to me the worst part is waiting for those 11 days for a pregnancy test. We will support the second part of the cycle with either some HCG injections or some progesterone. And obviously you're waiting for the result. I will usually try and call all my patients on the day of pregnancy test so that I give them the results. It's often a race between me and the nurses to get there first. Obviously, if it's positive, it'll be an ultrasound around 3 weeks' time. Now, at this point in time, when you do the blood test, you're 4 weeks pregnant. So we look at, that's just the way it works out. So when a woman is pregnant naturally, she's 4 weeks pregnant when she does her pregnancy test. And it's the same thing with assisted conception. If it's a negative result, I will discuss what the next steps would be. And there are other supports and resources there, such as the counsellors at Genea to talk to, because this can be a difficult process. At Genea, you have your own team. So I'm only part of the process. There are a lot of people involved. And I have a team working with me. So I have a nursing staff who will be the people who will be relaying your blood tests and ultrasounds to you. That tends to be the same nurses on my team all the time, so that you're dealing with the same people, and I'm dealing with the same people as well. As I've said, there are counsellors, there are geneticists who do the testing of the embryos, andrologists who will perform sperm assessments before assisted conception, and also prepare the sperm ready for the injection of sperm or mixing of the sperm with the eggs on the day of egg collection. The embryologists have a very important role, of course, in looking after the embryos in the laboratory and looking for the eggs, preparing the embryos for the embryo transfer. And there are, of course, the counsellors that I discussed previously. And last but not least, there are the patient relationship coordinators who do all of the administration around your cycle. So success rates at Genea are on the screen, and our success rates have climbed over the years. I've been doing this for such a long time. I've seen lots of innovations, such as we used to grow the embryos all together in one incubator. Once we changed to individual incubators, the temperature regulation was much better and success rates improved. So there have been a lot of changes over the years. Obviously, age is a really significant factor, as you can see here. So the success rates for fresh and frozen embryo transfer do vary based on the age of a woman. So when should you seek help? Well, as I said at the beginning, there was a sort of 6-month and 12-month arbitrary line in the sand, depending on a woman's age of 35. But if you feel something's not right, it's appropriate to do tests whenever you feel it's appropriate. Obviously, there'll be certain indications where you might do some extra investigations, such as recurrent miscarriage, or if there's a genetic condition in the family, or if you've been diagnosed with a condition such as polycystic ovaries or endometriosis. Endometriosis, I will mention one last thing, is when there are little blood blisters inside the abdomen. We don't know why endometriosis reduces fertility, but we know getting rid of it improves your chance of pregnancy naturally. If you do an operation called a laparoscopy, it's keyhole surgery, commonly with 2 little cuts on the tummy. They're about 1/2 centimetre, one in the tummy button and one low down about the hairline. And it's a day-stay procedure. And it's the one time you go to the doctor and you want to find something wrong, because if you have endometriosis and remove it, you improve your chance of pregnancy. If you don't find anything, then perhaps if you flush the tubes, that might improve your chance of pregnancy, but otherwise you're not changing your chance of pregnancy. So it's another investigation that I will do for certain patients before considering going on to assisted conception. So what are the possible next steps? Well, the next steps are for you to decide whether you wish to see your own GP, see our bulk billed fertility GP on site at Genea, book a consultation with someone like myself. Now, at the present time, we're right in the middle of the COVID-19 pandemic. And for the last few weeks, I have been performing all of my consultations by Skype, so no one coming into the rooms, just to try and reduce the risks of transmission, obviously, with people getting on trains, etc., coming into the city. The cost for this is exactly the same as if you came face-to-face. At the present time, there are no Medicare rebates for consultations by Skype with myself, but I've reduced the fee so that you are not out of pocket. Many of you will be concerned about whether to try and conceive with COVID-19. There obviously haven't been enough pregnancies with women who've been affected with the condition and who've gone on to conceive. There may be some issues with ladies having earlier deliveries if they're pregnant. We're not sure about the effect of COVID-19 on very early pregnancies. But the Fertility Society of Australia has not said that you should use contraception and not try and conceive at the present time, based on evidence from similar viruses such as SARS or influenza. But obviously it's a personal decision what you would choose to do.
So just going to go through some questions. And first question was from a lady who wanted to ask about polycystic ovary syndrome in detail and what are the options for those women who have the condition. Well, it's quite a lengthy discussion to discuss, but basically it's a lot of follicles in the ovaries, usually to do with an imbalance of hormones within the ovary. And that means that a little follicle where the egg comes from can't be released every month. So there's no ovulation, and therefore someone can't become pregnant. One of the simplest treatments for this is if someone's overweight is to lose weight, because if you lose weight, then you drop your levels of insulin in the ovary, drop levels of testosterone in the ovary, and then that makes a hormonal balance much better because there shouldn't be much testosterone around there. There should be a lot more estrogen, female hormone. There should be testosterone. That's one of the things we use. We also sometimes give ladies some insulin, some metformin, which works to reduce the insulin level in the ovary, to try and get that balance correct, let a follicle grow. We can use tablets to try and bring on ovulation, such as clomiphene or letrozole. We've moved more towards letrozole now. It's got higher success rates rather than the old clomiphene, which we used to use. We can use injections to bring on ovulation, or sometimes we'll do things such as IVF, especially if your partner's maybe got a low sperm count, for example. So that's probably polycystic ovaries. Next question was, are there any waiting periods for procedures? Well, there are no waiting periods at the moment because of COVID-19. As I said at the beginning, we've actually started IVF procedures again, so there's no wait to start any treatment. I've also been told the service for ovulation trying has been stopped due to social distance, and that's correct. That may come back again, but it's also about being responsible in the community because we want to reduce the number of exposures of staff and of patients to our staff because we want to protect you. We don't want you going for blood tests every day when we might put you at risk of COVID-19. So we're doing essential treatments at the moment. Ovulation tracking you can actually do by buying the ovulation kits from the chemist. So therefore there is another option out there rather than having to do the formal blood tests. So that's why we've stopped doing that at the present time. Obviously, we want to bring it back again, but we've got to assess the risk from COVID-19. Now, another question, is it normal to have a regular cycle over 30 days? Well, it can be. Not everyone has a 28-day cycle as per the textbooks, with ovulation day 14 and the next period 28 days later on. Some people will have a 32-day cycle, and that's quite normal as long as ovulation happens. The next question from the same person was IUI with hormone stimulation. So that's where we get the sperm and wash it up and put it inside the womb at the right time, as I described in the a couple of minutes ago. But we use some stimulation to try and increase the number of eggs. Now, that does mean more chance of a multiple pregnancy, which, as I said, we don't really want to happen. So I don't do a lot of IUI with hormone stimulation. IUI is more, as I said before, about not being able to have intercourse. Another question, what can we do to naturally boost our fertility without going to a clinic? Well, weight loss, not smoking, not drinking too much, keeping yourself healthy, and taking folic acid. There aren't really many other proven things out there. There are lots of things talked about, but there's nothing proven to improve your chance of pregnancy. They're the main things. Weight loss is quite a big thing in our community at the moment because a lot of overweight people, and it does contribute to infertility through lack of ovulation, etc., as I discussed. Next question, what are some of the causes, treatments of unexplained infertility? Well, I'm afraid the cause is we haven't got a cause, because unexplained infertility means that we've checked for the basics, the 4 things we're looking for. Ovulation, is an egg being released? Yes. Is there sperm? Yes, and it's good quality. Can they get together? Are the fallopian tubes open so the sperm and the eggs can get together? Yes. And is there a normal lining of the womb for an embryo to implant in? So if those 4 things are normal, then we've diagnosed unexplained infertility, meaning we haven't got a reason why it's not happening. Now, you could do a laparoscopy to look for endometriosis, and that's probably got to be done to say it's definitely unexplained infertility, because with endometriosis, there are not always symptoms to suggest that you've got the condition. And with unexplained infertility, treatments depend on how long you've been trying, because the couple who've written the question are 27 and 28 and been trying for about 18 months. Now, when you're younger, you've got more time on your side, so people will try for a bit longer before going on to treatments. And unfortunately, it's frustrating having to wait. Couple who are in their 40s, you'd be thinking of maybe boosting the chance of pregnancy a bit more quickly. So about 18 months, people could choose to go on and do other things, such as the ovulation induction with the IUI, which I just discussed, the medications to make you produce more than 1 egg and putting the sperm inside the uterus. But most people will tend to go towards the IVF process at a certain point in time, not because they can't get pregnant, but because it's not happened by that point in time. So as far as all of the, there's another question saying, I track my cycle and my GP has done all the tests in preparation to go to a clinic, and they've all come back normal. For us, what's another question about I diagnosed with unexplained infertility? So you basically just see a fertility specialist, and then they'll take you through what you should do from there. And if people will come to see me who've been trying for 18 months, and I'll say, well, look, maybe we won't do anything now, we'll give it another few months. But if it doesn't happen by a certain point in time, then we can move forward. So at least there's a plan and you know what the next steps will be, because I think that's part of it that's important. Another question, can you provide more information on the pre-IVF testing rebate in New South Wales? Well, New South Wales government is actually giving everyone doing pre-IVF tests, such as blood tests for AMH or ultrasound or a sperm test. If you've had out-of-pocket expenses, you can get $500 back from the New South Wales government. Now, I have to give you the form to say that you've been trying for more than 6 months to conceive if you're over 35, or more than 12 months if you're under 35. And provided you've got out-of-pocket expenses, you can get $500 back on the test, the out-of-pocket cost of the tests that you have actually had performed. Now, there was another question about rostering. Someone asked, do I see you as a specialist, or will I have another doctor for my procedure? I do all my own procedures 7 days of the week, except when I'm on leave. But of course, at the moment, no one's going to have leave because we can't go on holidays anywhere. So no, it's me doing all my own procedures, and that's at Genea. That's how it happens. A lot of other clinics will do, say, egg collections Monday, Wednesday, Friday, but we do them the days that are correct for you rather than putting you into a schedule for ourselves. So if someone needs an embryo transfer on a Sunday, I do an embryo transfer on a Sunday. I'll also talk to people at the end of the cycle, as I talked to, as I said a little while ago. I'll do talk about results, etc., with patients on the day their pregnancy test is due, because you need to know what the next steps are. Someone else has asked a question. Oh, so is that 500 per couple or per person? No, it's per couple, I'm afraid. It's not 1,000. It's only 500 per couple for the rebates. And from the scans, I found an intramural fibroid. Is it a high risk? It depends on the fibroid. So fibroids are little growths in the wall of the uterus, and they can be anywhere. If you imagine your uterus is like a pear turned upside down, and little growth in the wall of the uterus is not a problem if it's on the outside, on the skin of the pear, shall we say. That's a subserosal fibroid, and they're not usually too much of a problem unless they're very large, sort of above 5-6 centimeters. Even then, we just tend to leave them alone. Intramural means it's in the wall of the uterus. That's what intramural means. And they're not too bad as long as they're less than 5 centimeters. Above that, they might divert the blood flow away from the lining of the womb and might lower your chance of pregnancy. And the ones that we are worried about are submucosal. So those fibroids that are bulge into the cavity of the uterus. So if you imagine it's like the pear, that's the cavity, the core where the baby would grow. And if you've got one bulging into there, we do tend to treat those because they do affect the chance of pregnancy. Now, just going to see if there are any other questions. Oh, yes. Are there similar chances of infertility with stage 1 endometriosis compared to stage 3 or 4? I'm 27, my partner 28, trying 19 months with no other issues. Clomid 6 months and a laparoscopy to remove endometriosis. Well, getting rid of endometriosis, the more you get rid of, the better you improve your chance of pregnancy. But if everything is all normal apart from that, and it's been over 6 months since you've had your laparoscopy to remove all endometriosis, a lot of people might consider other options such as moving on to IVF. Again, not because you can't get pregnant, but because it's not happened by that point in time. So that's a usual arbitrary thing. So if you just had an operation, you've got rid of endometriosis, you want to give it a few months to see if getting rid of that will improve your chance of pregnancy. It also depends on sperm counts and what the tubes look like and etc. at that point in time. Now, next one, any research done on the effects of immune conditions and fertility? I'm 39 and have ulcerative colitis. I had my first ones through help from you guys 8 years ago taking Clomid. So ulcerative colitis, people can stay on their medications. Immune conditions are difficult because there are a lot of immune tests and we haven't always got the answers for immune conditions. We haven't seen any studies on ulcerative colitis patients doing worse than anyone else. Of course, during pregnancy, the ulcerative colitis tends to get a little bit better. Pregnancy damps down immune responses and tend to make things a little bit better, but of course it can come back worse, a little bit worse after the pregnancy has happened. So immune conditions are difficult. There are a lot of immune tests out there, a lot of controversy over whether you should do these tests. And some of the medications that we use for immune conditions, such as steroids, can have quite significant effects on mums and babies. For example, prednisolone can cause a cleft palate in a baby, an increased risk of cleft palate. So we've got to judge when we do tests and also judge when we use certain treatments. Is it a provision to select most healthy sperm? Well, if the sperm's normal, we just mix the sperm and the eggs together, as I said, the IVF process. Because ICSI is a little bit more traumatic. It does mean stripping the cells from around the outside of the egg and injecting the sperm directly into the egg. So that's more traumatic for the egg and might actually affect embryo quality. So we usually choose the best sperm if we're doing ICSI by choosing the best normal moving sperm to inject into the egg. But if the sperm's normal, we tend to do the IVF. We'll do some extra tests beforehand, checking sperm numbers, movement, shape, and also looking for any DNA damage in the sperm. Especially in smokers, a lot of DNA damage might mean less chance of pregnancy and more chance of miscarriage. How do you improve men's sperm quality and motility? Difficult one. There's a lot written on female fertility. There's not so much on male fertility. Obviously, same things. Not smoking, really important. Not smoking cannabis, that really affects sperm quality. Multivitamins won't do any harm. It's not definitely proven, but a men's multivitamin is not a bad idea. So weight, smoking, alcohol, caffeine. And people have asked me about bike riding. So a lot of cyclists out there, especially in these days, and sperm's produced in a cool environment. So it's best, that's why the testicles are outside the body. So people have said to me, well, bike riding, could it affect it? And you can't tell unless you stop the bike riding and see if things have improved. So we don't say have hot baths or go into saunas if you're sort of looking at sperm, usually motility. And the bike riding is a difficult one because lots of people who are on bikes don't have any issues at all. And it's not something I've said to people, it's not you need to put frozen peas on your testicles at night time or anything like that to make the sperm better quality. It's not going to do that. So just trying to loose-fitting underwear, boxer shorts, those sorts of things, and maybe not a 30-kilometer ride on a Saturday and a Sunday, and see if it does improve things. All you can do is try, but there's not a lot written. Next thing, can frozen eggs undergo PGS after fertilization? Does it put more risks on the embryo? Well, we used to be doing that. We've now changed our minds on that. I think with frozen eggs, it's best to thaw the egg, fertilize the sperm. You've got to do the ICSI process and inject the sperm in there, and then grow the embryo to the day 5. And I think it's better putting an embryo straight back into the uterus rather than refreezing it. Although embryos that have been frozen from a frozen egg still do quite well. But I think that the extra testing and extra trauma involved in biopsying the embryo may actually affect the implantation. So I would tend not to do the testing. Now, we did do that up until recently. It's just our latest stats have come up with that. So PGS is testing the embryo to look for the chromosomes inside. And to do it, as you've seen on the video, you've got to chop off some cells and freeze the embryo to wait for the results to come back. I think it'd be better putting the embryo back straight away, untested, rather than doing that. Another question, after attaching, is there any treatment that makes the embryo stick properly? There's not. There are various things we've used as adjuncts. Sometimes we'll use some clexane, sometimes use some extra progesterone, but there's not anything else. A little bit of it's down to luck, I'm afraid. Next question, what ovulation kits do you recommend? So there are lots of different ovulation kits. Sometimes it's cheaper to get them over the internet than from the chemist because they're pretty expensive. So I can't tell you just a particular one, but the urine ones are probably better than the saliva ones, I would say, for ovulation testing. Next question, how do you improve egg quality with supplements? There's no proof that we can. That's the bottom line. We all take supplements. I take vitamins in the morning. I don't know if they're doing me any good. So I can't say that there's a definite improvement. Folic acid is the only thing that has to be taken to reduce the risk of spina bifida. Another question, good question. Should endometriosis be treated before starting IVF? Controversial. So I will see a lot of people with unexplained infertility, been trying for 2 years to get pregnant. No symptoms or signs of endometriosis. And the things we're looking for with endometriosis are heavy painful periods, pain during sex, spotting before periods, family history of endometriosis. The longer you're trying, the more likely something's holding you back. An ultrasound with maybe a chocolate cyst on it, or a high blood test called a CA125. Now, if I've got a couple with me, and the woman doesn't have any of those symptoms or signs, we've got the option of trying to conceive naturally, laparoscopy to remove endometriosis, or IVF. If we do the laparoscopy and we don't find anything, we won't change the chance of pregnancy. So it's the one time you go to the doctor and you want to find something wrong because you want to get rid of endometriosis to leave you with a better chance of pregnancy. If you do the operation, you don't find anything, I often say to people, you feel ripped off. You've done an operation. It does have risks. It does have costs. It does have time off work, and it's not changed things. Now, some people will want to do the operation to know they've done everything before going on to IVF, and that's totally fine. And some patients will choose to go on and do IVF instead, because IVF will boost your chance of pregnancy by collecting more than one egg, taking the guesswork out of fertilization, putting the best embryo of the bunch back into the uterus. So IVF will lift your pregnancy rate. Laparoscopy might lift your pregnancy rate, provided you find something wrong and get rid of the endometriosis. Now, we're not sure if endometriosis affects IVF success rates. Some studies say yes, some studies say no. And that's why it's not mandatory to do before going on to IVF. We know getting rid of endometriosis lowers natural pregnancy rates. So a lot of people will choose to go on and do IVF. But I say if you've had 2 cycles of IVF and not become pregnant with unexplained infertility and not had a laparoscopy, we revisit the laparoscopy in case you're someone who doesn't have symptoms or signs of the condition. And that's the issue with endometriosis. You can have people with every symptom and sign, and you don't find a lot of endometriosis. And there are people with no symptoms or signs, and sometimes you will find it. So we never actually say we're not going to look at doing a laparoscopy. I discuss it with everybody, and we come to a plan based on where things are for yourself. There's no hard and fast rule. Now, what else have we got? If the woman is almost 40 years old and have been trying more than a couple of months continuously but no luck, do you think it is better to see a fertility GP now or trying for another couple of months naturally? Well, it doesn't do any harm to do the investigations now at 40. And the reason for that is you can check sperm to see you've got a chance, you can check the tubes are open, you can see ovulations happening, check there's nothing in the uterus, no anatomical things in uterus that would be holding you back. And then you've got the confidence to try for another few months. As I said at the beginning, a large number of people that I see don't necessarily go on to IVF. They will have other treatments or get pregnant on their own as well. Another question, does a gluten-free, dairy-free, red meat-free diet improve quality? There's no proof it does. We feel better when we punish ourselves and remove things. And if you've got celiac disease, then gluten-free will, of course, help. There's no definite things with any of those things removed from your diet. So no, there's not a definite improvement with those things. Even although some people do talk about it, there's no research suggesting that. Now, I think we're nearly at the end of the questions. So I'm just clicking off a few to see that I've done them all. Where else have we got? We've done that one. Is it better to transfer fresh or frozen embryos? Well, if you've only got one embryo and you freeze it and try to put it back in a natural cycle, there's a 1% chance it won't survive defrosting. And in that case, you'll wish you'd popped it back straight away. So we tend to put one embryo back fresh and then freeze any spare ones, because fresh and frozen have pretty similar success rates, I'll be honest. There's another question, why do some clinics transfer embryos on day 3 and some on day 5? Well, we changed to day 5 embryo transfers about 2002, so about 18 years ago, because if you've got 5 embryos on day 3 and only 2 on day 5, it helps you sort out the best ones to put back. So it gives you a higher pregnancy rate much more quickly. You don't have as many frozen embryos to go through if you've got 5 in the freezer and 3 of them weren't going to make it to day 5. We don't think they were going to form a pregnancy anyway, so it helps you get pregnant more quickly. So another question, if I've conceived naturally 2 years before, does it prove my tubes are normal? Do I need an HSG? An HSG is a test to see if your fallopian tubes are open. Well, one of your tubes was open at that point in time, that's all we can say. Now, unless there's been some other infection or operation or something that would affect your tubes, we can't say. And sometimes people will flush tubes just to try and see if flushing might improve your chance of pregnancy. So it doesn't mean that you've got both tubes open. At least all we can say is that one was opened at that point. One was open at that point in time. Now, let's see what else we've got. Do you provide hormonal testing, say through blood tests, to see if levels are too low or high before trying anything? Yes, we do lots of tests beforehand. And I don't know if you're talking about before doing IVF or in IVF, but during IVF, there are lots of hormonal tests. in particular before even an embryo transfer, to check it's safe to put an embryo back into the uterine cavity. I've heard of women with endo being hospitalized with pelvic infection after egg collection due to endocysts in the ovaries. How do you ensure endocysts are not infected or punctured during egg collection? Well, you try and avoid them, and you don't go for the follicles that would be behind those cysts. Now, I've got to counsel people that they may not get as many eggs, because if you've got the needle here, the ovary, and the follicles are all here, but you've got a big cyst between the needle and those follicles, then the best way to avoid infection is not to go for those follicles. So you've just got to accept that that's what's going to happen. Obviously, you do give antibiotics, but sometimes you will inadvertently puncture what we call an endometrium or a cyst in the ovary. It may be very small. It may be difficult to get to the follicles without doing that. So yeah, we just use antibiotics and care, but it's not a guarantee. Anyone, even without a cyst, could have an infection because you're putting a needle into your body. Even getting blood taken, you could have an infection just from having a blood test. What is your approach to patients requiring multiple embryo transfers in one go? No. So very rarely I will put 2 embryos back, but you've got to be a certain age group. You've got to have had lots of times trying, because it's a good question. Lots of people want to put more than 1 embryo back, but it's just too many risks for mum, too many risks for babies. And we want you pregnant with a safe pregnancy. We don't want you to have a twin pregnancy. Or even putting 2 embryos back, you could end up with triplets. One could split into 2 and the other one could go ahead. So for a long time now, we've been putting 1 back just from a safety perspective. Less risks to mum, less risks to babies. Another question, do you test for Asherman syndrome in women that have had previous miscarriage or terminations? So Asherman syndrome is where there are adhesions, little bits of tissue stuck inside the uterus. If you get a cut on your arm, your clothes will stick to your arm. And if you've had termination or miscarriage, you've had surgery on the lining of the womb, sometimes that could cause things to stick together. So yes, we do look out for that. We usually do an ultrasound before doing IVF. If we're doing the tube testing with the high COSI or HSG, you do that to see if there are any areas stuck inside. So it's not an absolute for every single person. If the lining is thin, it alerts me to someone who may have had some adhesions from a miscarriage or a termination. So any surgical procedure puts you at risk of that. Another question, my husband and I have already had our testing done through our GP. Do we need to get fresh testing done, or can we book in to see a fertility specialist straight away? No, you can see a fertility specialist straight away. So you have a choice of seeing your GP to do preliminary tests or coming to see me. And always bring all of the tests with you. That's one of the really important things, to save you having to repeat things and to give us the whole picture when we're going to when we do the consultation. How long does it take to cycle with frozen eggs to transfer? I work outside of Sydney. Well, it depends on your cycle, but if you've got a 28-day cycle, you do some blood tests where you live, sort of day 10, day 12, day 14, to see when you're going to ovulate, maybe with 1 ultrasound. On the day of ovulation, we thaw the eggs. You might thaw 6 eggs. Inject with sperm, 5 might fertilize. Grow them through to the day 5 stage, and you might have 2 embryos. And you'd usually put 1 back into your uterus and then freeze the spare one afterwards. So really, it would be 1 trip to Sydney for the embryo transfer. The rest of the blood tests before the transfer and afterwards could be done outside of Sydney. I work in Tamworth. I go there was going there every 2 months before COVID. I'm not able to go at the moment. I'm doing a lot of consults by Skype. And so, I mean, the people who work here in Tamworth will have bloods and scans done there and come down for egg collection and come down for embryo transfer. And I go up there and do 6 clinics a year for 2 days every 2 months to consult with people to save all those people having to come down to Sydney. Now, let's see what else. How recent do the preliminary tests need to be before going to a specialist? Look, we want things within the last year. I mean, old tests will give us an idea, but something from 10 years ago is not going to be that relevant. But a sperm test within the last couple of years, an ultrasound within the last 6 months. And anything that needs done, I will just order. If things are not up to the right dates, then we organize all of those things. You don't have to worry about that. I will do all of that for you. Another question, if I've had treatments elsewhere, is it possible to transfer embryos? Yes, no problem at all to transfer embryos from other clinics to Genea. In fact, if people have got frozen embryos at another clinic and going to have treatment at Genea, it probably saves money to have them moved over to Genea and pay one freezing fee to keep them frozen, which is about $42.90 a month, rather than having them in 2 different locations and paying 2 maintenance fees to keep the embryos frozen. So no, that's not a problem to do that. And we actually have someone called the transport coordinator who organizes that for our patients. Another one, how accurate is EMH as an indication of your egg reserve? It's a difficult one. It gives us an idea of egg reserve, so the number of eggs that we might get from IVF. So, as I said before, AMH, follicle numbers, and size of ovaries gives us an idea how many eggs you'll produce. But sometimes they don't all marry up. Sometimes the AMH may suggest this number of eggs, the follicle numbers in the ovary may suggest this number of eggs. And then we don't know how many you're going to produce till we do the process. And so it's nothing's 100% certain with any of this. Okay, someone's written not a question but a comment. Doing this webinar is awesome. Going forward, could Genea consider doing this into the future? You reach so many more people, otherwise it's often difficult to get to the venue normally. Yes, I think that we're all learning from this strange world we're living in at the moment. I think it's easier to be able to do that, and also it's a little bit more private. So it's certainly one of the things I'm considering for my patients in the country, because a lot of people know each other and people may not want to sit in a room with people that they know. So I think it's a really good idea, and we're certainly considering that. So thank you for that comment. What else have we got? I think we're nearly out of questions. I'm out of questions now. Okay, so look, we finished all the questions. What I'll do is we're going to put you onto the website now, where you could choose whether you would like to go on and see a fertility advisor, fertility GP. You can book that on our website. You can book an appointment with myself, although it will be Skype. It won't be face-to-face at the present time, and a whole lot of resources as well. So we'll just cross over to that now, so you could then look at that resource. But thank you all for your attention, and I hope it's been valuable. Thank you.